This conference will now be recorded.
Remember last time it said that?
Yeah. All right, well, I guess we'll start. So right here.
Right where, down here?
Okay. All right, thanks for coming, everybody. Today we're doing the second part of the Oasis for getting ready for Oasis E. So we're going to be talking about social determinants. But first, Elizabeth is just going to have a couple words.
Just saying hi, and I think at this point everybody knows who I am and what we do over at this end of the building. Does anybody need any brochures for their car? I ask that when you're in clients' homes, if they're in need of non-medical home care, that you have these handy-dandy trifolds and pass them out. Please provide them with our number to give us a call, and I'll go over rates and policies and all that stuff with them. Anybody need them?
They're going in the package for the
Yes,
bag,
they
right?
are.
So every
Oh, okay,
admission,
that's
they're
good.
getting one.
Yeah.
So at a
Okay.
minimum.
All right, perfect. Thank you. Enjoy
Perfect,
the
yeah.
cookies.
Thanks, Elizabeth. Okay, thanks everybody for coming. Okay, so we're going to do the social determinants. So, want to get started? All right, so
Right, the first one?
well, that's just the title.
Oh.
That's just the title. Okay, so social determinants, what are they and why are we going to collect them? So when we're talking about the social determinants for people, it's really where they live and it's where they work, where they play, where they go to the church, where their friends are. So it's their community that they come from. So basically, what you're looking at is what are the factors that are in that community or that's in that population of people that can affect the way that they get their health care or their access to things that they might need. They can have a big impact on the quality of patients' lives. And like I said, it can affect their access to things. So, and we're collecting them because then what we can do is look at the different populations. So what's the individual going through? What is the community going through? What is the whole population going through? And what are things that we can work on to improve the patient's quality of care and their outcomes? And also for our purposes, when we're doing the Oasis, when we're collecting some of that information, it's going to tell Medicare what our patient population looks like, what kinds of patients we're taking care of. And then what that will do also is it can kind of say, okay, this is the level of expectation that they're going to have on us with improvement of our patients, depending on what their status is and what's their vision like, what's their hearing like, what kind of access do they have, things, do they have caretakers, things like that. So if we collect all that information, it kind of goes into what the expectation is for them, thinking that we should improve them. Okay, so what are they? So ethnicity, race, language, transportation, health literacy, and social isolation. Those are the items that are going to be in the Oasis. And in this section, what we want to think about is social work. So when you're answering these questions, just think about, gee, what is it that a social worker might be able to help with? Some community resources, some long-term planning on things that the patients might need. Okay. So for some tips, so information in this section is meant to be self-reported by the patient. And all of the questions, you're going to mark anything that applies. So there can be more than one answer. Whatever the patient says the answer is, that's what the answer is. If the patient's not able to respond, you can use a proxy or a caregiver or the medical record to get the information. If you do have to do that, you also have to mark whatever the answers are, and then you also have to mark that the patient was unable to respond, and that's so that they know where the information is coming from. If the patient's able to answer a question but they decline, then you're going to mark declines because the patient doesn't want to answer it, so we're not going to use another source for that. And if the patient's not able to respond and there is no caregiver or we can't get the information anywhere else, we're just going to mark that the patient is unable to respond. And you'll see all that when you see the questions. So this next one is just, this was more for me, just to remind me when I was going to go through this, that race and ethnicity right now, it's pre-populated in intake and it together, and there's these 6 choices. So that's what we do now. So when we go to Oasis E, what they've done is they've taken those questions and they've divided them. So now they're going to be 2 separate questions. So the first one's going to be ethnicity. That's going to be collected at start of care. And this one is not going to be pre-populated from intake. So when you go and you do the start of care, you actually have to ask the patient so that you can get the information. And what you're going to ask them is if they're of Hispanic, Latino, or Spanish origin, and they can say no, they're not, or yes, and there's Mexican, Puerto Rican, Cuban, or another Hispanic. And then if they're unable to respond, if you get that information from someone else, you would mark what it is and you would mark the patient unable to respond. If the patient says, I don't want to answer the question, you're just going to mark patient declines. Okay? And then you have race. So this one is still going to be pre-populated at intake. So when you go out to admit the patient, whatever they get will be there, and you're just going to update it to whatever it is that the patient, wants. And they've also expanded it. So there's 14 different choices that they have. So that you're just going to make any updates. Okay, so that's that one. Then we have language. So language is also going to be answered at start of care. Right now, I know that when intake does the referral, we usually put what the language is. I don't know if you see that on your side or not, and you have the ability to change it. But what you'll be doing is just typing it in now. It's not going to be a checkbox. So whatever the patient's preferred language is, it gets typed in. And then there's also a second part, which is does the patient want or need an interpreter? And if they decide that they do, then we have to, make sure we get the interpreter, because we want to make sure we're communicating with them in a language that they understand, so that they're going to be able to follow the plan of care, and we're going to have a better chance of improving their outcomes. We want to break down any barriers that we can. So does anybody have any questions on anything so far? Okay. So we have a new question again now. It's on transportation. So now what they want to know is if the patient has any transportation difficulties. That's done at start of care, resumption of care, and discharge. And really what the reason for this question is it's divided into medical access and non-medical access. And you have to ask the patient, it's a time frame of over the last 6 months to a year. And they want to know, has a lack of transportation kept you from medical appointments, meetings, work, or from getting things that you need for daily living? And then it's whatever the patient says. If they've been having difficulty, if it's medical reasons, you can mark medical reasons. If it's non-medical, it could be both. So again, it's mark all that apply, whatever the patient says. If the patient's not able, you can use a proxy to get that information, and you would just mark that the patient's not able, or the patient can decline to answer it. So the thing on this one is to remember is when you're asking the question, the time frame of 6 months to a year isn't actually in the question. So that's just something to try to keep in mind that is what it is. Okay. All right, so I have an example for transportation. So how are we going to answer it? So the scenario is Mr. T reported over the last 6 months that he sometimes had trouble getting to the senior center and he missed the medical appointments. He has a neighbor who helps at times but is not always available. After his hospitalization, his sisters will be staying with him for a while until he's safe to stay alone and will be helping him. So now you're admitting Mr. T to service. How are you going to answer transportation? Anybody? A. Right? A and B, right? He has trouble with medical appointments, and he also had trouble getting to the senior center. So it's gonna be A and B.
Wouldn't appointments in B also cover the medical appointments?
Appointment, no, they specific, so no, so what they're, with appointments in B would be like some kind of social appointment or something that he had, okay? So what they're getting at is they specifically want to separate anything like medications, pharmacy, that kind of thing with your social stuff, okay? All right, so now, next one, that's the answer. And the reason is in the past 6 months, he had trouble with medical and non-medical transportation. Okay, so that's easy enough. All right, so now we're gonna discharge. So at discharge, it's a month later. When asked about transportation, Mr. T reports that although he had trouble over the last 6 months, currently he's not having transportation difficulties. His sister is bringing him to medical appointments, and she picks up his meds and does the grocery shopping. So now at discharge, how are we gonna answer this one?
C. No, let's say A because it's nothing, there's nothing to say about non-medical stuff.
Well, okay, so
She's picking up the groceries for him, she's not
right.
driving to it.
Okay, so the point with this scenario is we still have to remember what the time frame is. So the time frame is within the, I know, but, and I don't really understand that either. I'm not really sure what it is, except I think they might be looking for, once you establish, is there consistency over at least a 6-month period for the patient so that there's no gaps in things. So that's kind of why I think maybe they left the time frame like that. I don't know. So if you go to the answer, it is going to still be A and B, because within the last 6 months, he had difficulty. I know, and what they're saying, and they actually, right, I know. So this question is, it's not like one of the functional questions, like how was he at start of care, how was he at discharge? CMS is trying to establish, from what I'm trying to rationalize from this question, is does the patient have consistent help over a period of time, so that whatever we put in place is going to last. So if we had a patient that was on for 7 or 8 months and we worked on transportation and he's been getting, then yes, we're going to say, you know what, at discharge that transportation's been established and he's not having any difficulties.
But this is a discharge question.
Right, but the time frame is less than 6 months.
So this answer is not going to change till at least
the answer's not going to change till
We're adding
6
discharge,
months.
so we're not going to see him after.
Yeah.
So-
Right. And what you have to remember too with the new Oasis, it's coming from different facilities across the spectrum. So this question was developed, I think, like in a short-term rehab facility. So sometimes the questions are gonna have a little bit more meaning for one type of facility and maybe not so much for home care and that kind of thing. And there's already been questions about, gee, what do you mean by this? To CMS, and we actually got one in the email today. They're trying to explain what they mean by the questions and how you're supposed to answer them. And a lot more of that, I'm sure, will be coming once we start using it.
Plus, Mr. T's gonna pity the fool who go down. Everybody gets that, right?
Yes.
Everybody gets it?
So anyway, the point is the time frame is 6 months to a year. Okay.
Was in high school.
Yeah.
Mr.
I
T.
got it.
So health literacy. So now we're going to have to answer a question about health literacy. And we all know that health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. So, and the statistics are 9 out of 10 adults are not hearing or understanding what their instructions are. So that's really high. So we want to make sure that when we are teaching the patients, when we're, putting everything in place, we're using that teach back, which we see documented all the time. But that's going to be one of the best ways that we're going to be able to determine if the patient is really understanding what we're saying, and actually demonstration of what it is we've taught them. If they can demonstrate, put it into action, apply it to whatever they're doing in their daily lives, that's really going to show us that they really are understanding what we're teaching. So if they have poor health literacy, it causes more emergency room visits, more hospitalizations, people have higher mortality rates, and it's really, really linked to worse outcomes. So we really want to pay attention to what the understanding is that everybody has with what we're trying to do with them. Okay, so what does the question look like? So that's the question that's in the Oasis. And you're going to ask, how often do you need to have someone help you when you read instructions, pamphlets, or other written material from your doctor or pharmacy? And their choices are never, rarely, sometimes, often, or always. Patient can decline to respond. If the patient's not able to respond, you're going to mark he's not able. With this question, you cannot use a proxy or the medical record. It's patient only. So either you're going to get the answer from the patient, or we're not going to, we're going to say patient didn't respond. Okay. Next question is social isolation. So when patients are socially isolated, it's really about what's their perception of being lonely. Do they live alone? Do they not really have access to people or things around them? And it can cause depression. It can really impact and interfere with the plan of care that we're trying to provide. So we want to really try to get a handle on if they do have social isolation, again, what can a social worker get in there? What kind of programs and things can we get the patient involved in? So for this one's done at start of care, resumption of care, and discharge. And we're going to ask the patient, how often do you feel lonely or isolated from those around you? And again, it's self-report. Patient has a choice of never, rarely, sometimes, often, always. They can decline to respond, or they might not be able to respond. This one, like health literacy, also is patient only. So you can't use a proxy or medical record for this one either. So those are the two. All the other ones you can get information from somewhere else. Okay, so we have a scenario. So at start of care, when the nurse asked, how often do you feel lonely or isolated from those around you? Mrs. S responded, I used to feel lonely most of the time, but now that I live with my daughter, I rarely feel lonely anymore. So at start of care, how are we going to answer? How would you mark this? Rarely, right. And at discharge, now she's discharging. She wants to find out the same thing. So when she asked her, how often do you feel lonely? She says, I feel so much happier being around people. I'm hardly ever lonely.
Rarely?
Yeah, well, you know what? Never, rarely, it's not right or wrong. It's clinical judgment, but basically you're not going to say like always or most of the time or sometimes, but never, rarely would be fine. And the reason is, even though before, so unlike the transportation, this one is what's going on right now. So even though she was lonely prior to being with her daughter, when we admitted her, she was with her daughter, she wasn't lonely, so we could, say everything's good right at start of care. And then at discharge, nothing's changed. She's still with her daughter and she's still not feeling lonely. So that's the difference. It's the time frame. Okay. All right. So does anybody have any questions on any of those? Okay. So those are the social determinants. So I'm just going to go over some other factors that can also affect the patient's care that we're going to answer when we go through the Oasis. So we have hearing and vision. Hearing is a new question. Vision has been changed a little bit. It's been updated. We have mood, which is the depression screening, the PHQ-2 questionnaire that we ask. Risk for hospitalization that we already asked. Pain, they've changed the pain a little bit, so now you're going to ask about 3 specific areas of pain rather than just the one question. And falls. And again, these things about the patients are all going to go into what our patient characteristics are, what does our patient population look like to Medicare. So we want to make sure we give them the best information that we can about our patients. Okay, so the first one is hearing. Hearing's done at start of care. And the question is, what's the patient's ability to hear? And that's with a hearing aid or a hearing appliance. So if someone doesn't have a hearing aid, maybe they have headphones, maybe they use an amplifier, whatever it is that they use. That's what you're going to assess them with. Just make sure they have it and it's working properly. So it could be adequate, which is really no difficulties. You know, it's hearing, normal hearing. Minimal difficulty would be like in some environments, if you speak softly, or if it's noisy around, they might have a little bit more trouble hearing exactly what you're saying. Moderate difficulty is when you have to really kind of look at the patient, you know, one-on-one, really focus with so that they can pay attention and understand what it is you're saying. And then highly impaired would be basically they can't hear you at all. Okay, so those are the choices that you have. And with this one, we want to make sure, going back to when we did the mental status interview, we want to make sure that the patient can hear what we're saying, because we don't want to, you know, label somebody as having dementia versus hard of hearing, or just not, you know, wanting to be involved with what we're doing. So hearing is one of the things we really want to make sure that we're getting correctly with the patient. Okay, vision. Vision's done at start of care. So right now, when we answer the vision question, you have, like, I think it's normal, partially impaired, and severely impaired. Those are the 3 selections that you have to pick. They've changed it a little bit. So now it's what's the ability to see in adequate light. Adequate light is defined as lighting that's sufficient or comfortable for a person with normal vision to see fine detail. So it's bright in here. If you have your appliance that you're supposed to be wearing on, can you see? That would be your normal vision. So that would be adequate. Impaired are, okay, you have to have things in a little bit larger print. Moderately impaired, vision is limited. You can't see newspaper headlines, but you can identify objects in the room. Highly impaired would be object identification is in question, but their eyes follow objects. It looks like they're kind of following things around them. And severely impaired would basically be blind, unable to see. And what you want to do is make sure they're using whatever it is that they usually use for small up close print. This is a little bit of a change also. Right now, you're only supposed to be able to use their glasses, but some people use magnifying glasses that used to not be allowed to be counted. But if that's what they usually use, that's updated guidance, and you can now score them with a magnifying glass if that's what they do. And then just remember our patients that might not read English. You might want to use numbers and, you know, pictures, things like that, you know, besides reading. So we're making sure we're just getting to what their vision is. Okay, next. All right, so the next one is our PHQ-2 screening. It's now called the mood section. And this is the depression screening that we do. So the reason that this is used is because it's a standardized tool, it's a standardized assessment, and by using it, it doesn't diagnose depression, but it can screen for patients that might have some underlying things going on. And they did just change the question slightly. So now it reads, over the last 2 weeks, have you been bothered by any of the following problems? And then you're going to ask them little interest or pleasure in doing things, yes or no. Feeling down, depressed, or hopeless, yes or no. If they answer yes, then you're going to want to ask, well, how often are you bothered by that? So that's where then in column 2, you're going to score the frequency of how often they're bothered. With this one, if you get a 2 for either of these responses, then the instruction is to go ahead and finish the rest of the questions and do all 9 and do the whole PHQ 9. If you get a 0 or a 1 in both of them, then you can stop the interview and you don't have to go any further. So, and again, this is like anything else. You have to do it at start of care, resumption of care, and discharge. You can do it anytime that you feel like you might be seeing a change in the patient and you want to do it. So it is always available as a tool if you think there might be something going on and you want to screen. But those are the time points that you absolutely have to do it. And we really want to make sure that we are screening for depression and looking for it, because we know that it's really underdiagnosed, it's undertreated, and we really want to be able, if we get any information, we want to notify the doctor, we want to put any interventions into the plan of care that we need to follow up with this. And when you're going along doing this, asking the questions, not that we can't add 1 and 2, but the computer all the way down as you go will tally up the score for you, and it'll put it at the end. Okay, so risk for hospitalization. We already addressed the risk for hospitalization. That's done at start of care, resumption of care, and it's also going to continue to be done at follow-up. And the reason that we really want to make sure we're looking at this is we're really working hard to reduce our hospitalizations. And these are things that have really been shown that are factors that could really impact the patients, put them at a higher risk for having to go back to the hospital. So they're things that we really want to work on and address them if we find that they apply. History of falls. Do they have unintentional weight loss? And when we're thinking about the unintentional weight loss, it's of 10 pounds or more in the last 12 months. Is it because of illness, or might it be because they don't have access to food or their finances? So, kind of think about that. And if it's illness, obviously, we're going to clinically treat that. And if it's finance and access, then we want to, say, can we get that social worker in there? What can we do to help the patient get access and, to the food that they need? Multiple hospitalizations, multiple emergency room visits. If they've already been to the hospital, they've already been to the emergency room, chances are they're going to keep going back. Have they had a decline in mental, emotional, or behavioral status in the last 3 months? And they define that as it's a change in which the patient, family, caregiver, or physician has noted a decline regardless of cause. It can be temporary or permanent. The physician may be consulted, may not be consulted. So it doesn't have to be something that's diagnosed. It's just, the patient's just not the same. They're not their normal selves for whatever reason. There's been a decline. And again, that can impact how they're going to follow their treatment plan. So we want to make sure we're addressing that. If there's been difficulty complying with medical instructions, we want to look for that. How can we help the patient to be able to better comply? What are we going to put in the plan for that? Is the patient taking 5 or more medications? You know, the more medications the patient takes, the higher risk there is of med errors and adverse events, and then they end up in the hospital with medication issues. Patient currently reports exhaustion or other factors. Maybe there's something else that's going on with the patient that's not on here that you think, you know what, this might be a problem. I want to pay attention. You just want to, you know, mark that down and make sure you're addressing it. And this one is used in the calculation for our PDGM payment for the patients. So that's why it's done at follow-up also, because that payment is recalculated. And in order for it to be used in the calculation, the patient has to have 4 risk factors out of the first 7. So if the patient has 4, then it's going to be used in that calculation. Because the higher risk, the risk that the patient has to go back to the hospital, the more resources you're probably going to need to keep them out of the hospital. All right, so pain. Okay, so pain is done at start of care, resumption of care, and discharge. And pain it's subjective. It's whatever the patient says it is, whenever the patient says, wherever it hurts, however much it hurts. So it's very subjective, and it's all about what the patient says it is. Some patients don't like to say I have pain, but they might refer to being uncomfortable, or I hurt, or I have some discomfort. So, you know, we just want to make sure that when we are talking about pain, if they don't like to use the terms pain and the use, then we're going to talk in whatever language is going to make them feel comfortable. Okay, so it's 3 separate questions. So they want to know specifically, what's the pain effect on sleep? What's the pain interference with therapy activities? And what's the pain interference with day-to-day activities? So when you're talking about pain, there's no definitions of what we can give them, you know, when they're telling us what they think their pain is. If they're not sure if it's occasionally or frequently or whatever it is, if they're kind of stuck between 2, we're always going to score higher. So we're going to give them a higher frequency if they can't really decide which one it was. And also, the time frame has changed. It used to be in the recent past, and you know that meant whatever anybody thought that meant. So now it's specific time frame of over the last 5 days. So that's what it is. That's what we're going to ask about. And then if you're talking about something and they're not sure, they can't remember, just, you know, I hurt myself, or I had pain the other day when I was walking. Well, okay, well, when was that? I don't remember. Well, you know, what were you doing? What day it was? Try to help them narrow it down so that we can kind of get into that time interval that they're looking for. And for this one, what I see a lot when I look at the Oasis is the frequency of pain is what is marked, not necessarily how much the pain is interfering. So that's what we really want to look at when we're looking at this question. So I might have pain every day, but it might not affect my activity every day. It might be occasionally. So that's what it is that I want to measure, the occasional amount of time that it's actually interfering with what I'm doing and interfering with my activities. Okay, so this is what it looks like on the iPad. And I put this one here just because I wanted to remind everybody what that little eye in the circle, what that little eye is. Does everybody know what that is? Yeah, it's the information. So every Oasis question has that. So if you're not sure how to answer the question, if you're not sure what the guidance is, you can click on that and it will show you all of the information about that question so that it'll help you answer it. Okay? And if you ever have any questions also, you can always call myself, Julianne, or Jill. We're always more than happy to answer any question that anybody might have if you do need some help. But that is there for you if you want to use that to get some information. Okay, so the first question now about pain is, what's the pain effect on sleep? And this is the gateway question. It's got a skip pattern to it. So if you're asking the patient, gee, over the last 5 days, has pain made it difficult for you to sleep? And they're saying, I haven't had any pain whatsoever. You want to make sure that it wasn't just about sleep, but that they haven't had any pain for any activities. And if they haven't had any pain whatsoever in the last 5 days, then you can mark 0, it does not apply, and you're going to skip the next 2 questions and go to the next section. All right? So you might have a patient that's not having any difficulty with pain while they're sleeping, but they might be having difficulty going down the stairs once they get out of bed. So they do have pain, so you can't skip the section, but for this question, they don't have any pain. So in a case like that, for this question, you would mark rarely or not at all, and then you would go on to the next question. So that's the difference between skipping it altogether and then no for the sleep, but then you have to go on and answer. Does that make sense? Okay. All right, so we determined patient might not have any pain around sleep. They do have pain, so you're going to go to the next pain question. And this one is in reference to rehab therapy. So they want to know, in the last 5 days, have you had any pain? Has it limited your ability in attending rehab sessions? So what the definition of rehab sessions for this purpose is, it's healthcare service or programs that help a person regain physical, mental, and/or cognitive abilities that have been lost or impaired as a result of disease, injury, or treatment. So we're talking about PTOT, ST, cardiac rehab, pulmonary rehab, so whatever kind of therapy they might be going to. So again, in the last 5 days, if the patient hasn't had any rehab scheduled or they're not attending any sessions, then it's not going to apply because they didn't miss anything. If the patient had rehab scheduled but they didn't attend, then that's when you're going to find out, was it rarely or not at all, occasionally, frequently, almost constantly, or they're not able to answer. So when we're admitting the patient, this might apply to someone that's coming from short-term rehab that maybe was having rehab sessions right up until the time they left. So we want to know, gee, were you able to attend those rehab sessions, or was pain keeping you from doing that? So at discharge, things like if we gave them home exercise programs, or maybe they're canceling some of our therapy visits because they're having too much pain or something like that, then that's kind of where we would look at, gee, how often did that interfere, if it interfered in the last 5 days. So it's really those more formal rehab sessions that they want to know about in this question. And then once you do that one, it's pain interference with the day-to-day activities. And that's pretty much everything else that the patient's doing. So it's over the last 5 days. How often have you had to limit your day-to-day activities? And not including any rehab sessions that you might have had because of pain. And again, it's rarely, occasionally, frequently, almost constantly, or they're not able to answer. Okay. All right, scenario. Okay, so at start of care, Mr. P reports that he has chronic back pain and it was aggravated by his fall. He rates that the pain's 5 out of 10 and states that the acetaminophen helps take the edge off. This allows him to perform his ADLs, and the pain only occasionally limits his activities. So this has been the case in the last 5 days. So at start of care, how are we gonna answer? So we know he has pain pretty much chronically all the time. So remember, we're scoring how often it interferes. Yeah, it's going to be 2. So even though he has chronic pain, it was aggravated. It's interfering with his ability occasionally. Okay, good. Okay, so we're going to discharge. So at discharge, he reports that his right leg muscle spasms that he has at night still occasionally wake him up, but the back pain is effectively managed with the acetaminophen and it no longer interferes with his activities. The nurse asked, when was the last time you were woken up by the spasms? And he replied, about 3 or 4 days ago. So as far as interfering with sleep, has over the last 5 days, how would we answer that one? It was within 3 or 4 days, so we have our time frame, right? And he said, what did he say? Occasionally wakes up. So I would say probably 2. And how about interference with day-to-day activities? Right. Yeah, right, because it doesn't interfere anymore. So at discharge, he's still occasionally bothered with his sleeping, and his day-to-day activities, or he's managing fine. Okay. So improvement. Okay, so basically when we're looking at the patient's pain through the course of care, we've admitted the patient, we've assessed what it was, we've put interventions in place, now we're getting ready to discharge. So what we really want to know is, were we able to effectively decrease the amount of interference that it's having with what he's able to do on his day-to-day activities? He might still have some pain, but did we lessen how much it's going to interfere? So did he have therapy? Is the patient on medication, and is it effective? And are there maybe some non-pharmacological interventions that are in place, so that we can say, you know what, we went in there, there's less interference, and we've improved that patient's pain. Does anybody have any questions on how to do the pain section with the skip pattern or anything like that? Okay, good. Okay, so the next thing is falls. So the majority, the majority of falls do happen in the home, okay? And we know that elderly are very susceptible of falling, and once they fall, they're probably going to fall again. Okay, so what is the definition of a fall? It's an unintentional change in position coming to rest on the ground, floor, or onto the next lower surface. It could be witnessed, it might be unwitnessed. If someone pushes somebody else, that's not considered a fall, because that's an external force. I pushed you down, I didn't kind of go down on my own. Or we can have, so for Oasis purposes, we also have intercepted falls, and there are almost falls. Oops, I tripped, I almost fell, but I didn't. So that's what those are. And it occurs when a patient would have fallen if they didn't catch themselves, if maybe there wasn't something there to catch them. Stumbling up and down the stairs, you grab onto the handrail so you don't go down, but if that handrail wasn't there, you would have gone down and fallen. So for Oasis purposes, intercepted falls and actual falls are used in our tracking of that. We answer that question at transfer, discharge, and death at home.
That's a question?
Yeah.
Maybe just because I don't understand. So you're doing something with the patient, maybe you're standing by them, with them, and they look like they're about to go down, but you help them down.
Yes.
You literally help them down.
That's considered a fall, yes, because you intercepted them going down and you helped it to the ground. So yeah, that would be considered. considered a fall. And also by the same token, if a therapist is working with a patient and they're challenging them, whatever, you might be doing whatever you do to challenge them. So if they fall during that, that's not considered a fall because you were testing them and trying to work with them. Yeah, so that those are not considered falls. But if you're walking with the patient and they fall, that would be considered a fall. So just the fact that a therapist is with the patient doesn't necessarily make it a fall or not a fall. It depends on how you're working with the patient. Okay. All right. And also, just an FYI, when someone falls, we do that incident report. On intercepted falls, do not do an incident report. That's not an actual fall. We're only going to do that incident report if the patient actually falls. Okay. Yeah, we don't want to give Leah more than she already gets. Okay. All right, so Matt and Eric just did it in service, so I'm just going to kind of reiterate a couple things. So at start of care and resumption of care, we're going to assess the patient's fall history. We use the Mach 10. We also use the risk for hospitalization tool, so that's going to give us information. We can look at their medical records. We're going to talk to the patient, talk to the caregiver, find about any history or anything that we can. We're going to implement fall prevention strategies. So if the patient had prior falls, we're going to try to determine, well, why? What were the circumstances? What are the things that make the patient falls? And what can we put into the plan of care right up front, right when we admit them to try to prevent that from happening again? Implement therapy, implement a falls prevention program, safety hazard modifications. We want to check and make sure equipment and devices are in good repair and working properly. And I see documentation from therapists a lot, adjusted the walker, whatever it is that you're doing. So, looking at that that equipment is important. Medication use. What kind of medications is the patient on? Are they on high risk meds? Things that are going to maybe put them at a higher risk for falling. When are they taking the medications? Are they taking sleeping pills and then trying to walk to the bathroom at night? So it's all those things that we can try to put together to prevent. We're going to update the care plan at any point during the episode as we find out things, we implement things, and we're going to use the fall prevention guide policy as a guide. And every patient that comes on service should have a fall risk care plan in their, as a part of their care plan, and the appropriate interventions should be in there. And just an FYI, that question that is in the Oasis now was a standardized tool used to assess for fall risk. That question is going away, so we won't be answering that one anymore. Okay, so if the patient actually does have a fall, we're going to follow up. We're going to notify the doctor and the other team members. We're going to assess the patient's status, and we're going to follow up as appropriate. And we always notify the doctor whether there's injury, no injury, whatever the case might be. So it's something that we need to make sure we're reporting. Complete an incident report, including that post-fall assessment portion on the bottom. So if you do get information and you are able to collect some of that, what it's going to do is it's not only going to give us information about that particular patient's falls and the reasons they may have fallen, but we take that information and we pull it all together and we can get trends and we can see, gee, we have a lot of patients that fall because they're reaching for things. So we can just kind of say, hey, that's something that's a high fall risk. Why don't we just put things to help prevent that right in the plan of care and things like that. So we can really use that information for not only the patient, but for our whole population in trying to figure out good interventions and good fall prevention. You're going to complete that fall report in the medical record, that section under falls. And also we're going to reevaluate and update the care plan and re-educate the patient and the family as we need to, so that we can, prevent it from happening again. Okay, so how are we going to answer the Oasis? Okay, so we answer the falls on transfer and on discharge. So we have to kind of, we've gone through that whole admission with the patient, and sometimes they've been on for a long time and, trying to remember what happened with the patient. First, we have to determine if there were any falls, and it's going to be either no or yes. So for, things that you want to make sure you include are any fall that the patient had at any time during the episode, regardless of where it occurred. So if the patient went to the doctor and he fell at the doctor's office, we have to report that. If the patient went to church and he fell, we have to report that. So if it happened on our time, we report it, even though it didn't happen in the home. What we don't want to include are falls that occurred prior to the start of care. So especially we get so many doctor referrals because patient fell, please go out and, see the patient, put something in place. And sometimes what I'll see on discharge is that fall that the doctor called us about, we're including in, on the Oasis. So anything that happens prior to when we admit the patient, that is not going to be included on our Oasis because that was before we admitted the patient. And then also if a patient falls and he's transferred to the hospital, he comes back to us and later on down the line we discharge, we're not going to reach back to that start of care and include that fall again, because when you've transferred the patient and you filled out that transfer Oasis, that fall was on that Oasis. So when they come back and we do a resumption of care, we're starting from zero again. Because we don't, we already counted that fall. Once we don't want to count it again. So that's why it's kind of important to know what your dates are, if there was a resumption of care, so that we're not, including things too many times. And falls are now publicly reported on the internet, on our Care Compare site. So, we want to make sure we have accurate information about. They report the percentage of patients that have major falls in your agency. So we want to make sure we're accurate with that. Okay, so how are we going to, once we've determined that the patient had a fall, we have to now say how many falls did the patient have and what was the highest level of injury. So when we're doing this next section, we want to score the number of falls, not necessarily the number of injuries, because if the patient had one fall and two injuries, we only want to account for one fall. Okay, so we're gonna code each fall only once, and we're gonna code the highest level of injury that the patient has. So for an example here, we have a patient that fell and scraped his knee and broke his arm. So he had one fall and he had a minor injury and a major injury, right? So when we go to fill out the Oasis, we're going to put 0 in A. He had 0 falls with no injuries. We're going to put a 0 in B, 0 falls with minor injury, because we're going to account for that fall in C, 1 fall with a major injury. Okay, does everybody get that? Okay. And then now we have a patient that fell twice, so we have to account for 2 falls. So he fell once with no injury and once he had a cut arm. So we're going to score that one. A, we're going to put a 1 because he had 1 fall with no injury. B is going to be 1 because he had 1 fall with a minor injury. And C is going to be 0 because he didn't have any falls with major injuries. So it's going to be 1, 1, 0. And then just as a reminder, we had a patient that was admitted after receiving a referral from the doctor due to multiple falls. And the last fall occurred yesterday at the doctor's office. And then they called and said, oh, patient fell, please go out and do an assessment, admit him to services. Maybe he has wound care or whatever. So now way down when we're doing either a transfer or a discharge, we are not going to count that fall because the patient fell before we admitted him to our service. Okay? All right, good. So part of doing the falls is tracking them. So I actually got a discharge Oasis yesterday, and the question was left completely blank. So that requires a chart review. And the longer the patient's on service, the longer you have to go back and look at all the notes and look at everything that's going on with the patient to find out if they fell, when they fell, whatever the information might be. So if we can track our falls, it's going to make it a whole lot easier for everybody when you're answering the Oasis. So we do have a mechanism for that, and it's a triage note in communications. Okay, so when you go into your communications to write a note, you pick the note type that's triage. It's the very last selection in there. The only time you should ever pick that is if you're documenting something about a fall. And then that way, anybody that looks at a triage note knows, oh, okay, there's something about a fall for this patient. And it's very quick and easy to do. We need the date of the fall and what kind of injury was it. And that's because when you answer the Oasis, you need to know what your dates are and you need to know what your injury is so that you can mark the right box. So if I had a patient that I admitted to service on January 1st, had him on service, and on January 10th, excuse me, he fell and went to the hospital. I did a transfer Oasis. I accounted for that fall. We're all set. Everything's. Now he comes home on January 15th. We do a resumption of care. March 5th, I have to discharge the patient. Okay, now I got to answer the question about falls. So the easiest way to be able to do that is to be able to go back into communications and put your triage notes and just look down and say, okay, what were the dates, any falls, what was the injury? And for this patient here, he had a fall on 110, that was a skin tear. My rock was on 115, so that right there is going to tell me I'm not going to include that fall. So, you know, they're listed nicely, and it's just easier, and it's a good tracking mechanism to help us so that when we have to answer this at the end, we're getting the accurate information that we need.
If the patient fell and got transferred, you put that down as a fall, and when they got resumed, you put that down as a fall again? And then
No,
they got
nope. So what happens is we admitted the patient, they fell, we put it on our transfer Oasis, right? So it went to the hospital. We do a resumption of care. At resumption of care, you don't document anything about falls, right? So we haven't documented anything yet, right? So now I know my resumption of care was on January 15th. So now on March 5th, when I go to do my discharge, that's when I'm going to answer, did the patient fall? Because that fall happened on January 10th, which was before my resumption of care, it's not going to be included in that discharge.
So the slate is wiped clean?
The slate is wiped clean, yes. And the reason that it's wiped clean is because we already counted it, right? We already counted it. So we don't want to reach back and count it again, you know. We only want to count it when it happens, all right? So otherwise, you know, if we keep, we have some patients that are on for a really, really long time. By the time we discharge them, they're going to have 55 falls, you know? So every time they go to the hospital, what gets wiped clean. And you know what? And that brings up again, every time your patient goes to the hospital and we do a resumption of care, our is it called a quality episode? Even though the patient's still admitted on service, our quality episode starts all over again. And that's all of our functional items. It's all of our star ratings, everything about the patient that we're answering it. So a resumption of care is exactly like the start of care. So you're assessing that patient all over again. And that's one of the reasons that it's so important when our patients do go to the hospital, that when they come home at a resumption of care, we are actually looking at them all over again, like, gee, you're just on service. What is your status actually like right now? Not what were you before you went to the hospital, or kind of, where were we along the way? But did you have an exacerbation and now is your status worsened? And we need to reassess those things and kind of start all over again. Because that is going to affect our outcomes and everything down the road from a resumption to care now instead of a starting care. All right, so just quick, I want to just remind everybody about ambulation. Ambulation is like the crux of our functional items. If the patients can't ambulate and get to where they have to go, we're not going to improve a whole lot of other things. So this is one of the things that we're really going to look at going forward. It's involved in our value-based purchasing, it's involved in our PDGM, it's involved in our star ratings, and it's involved in the patient's outcomes. And are they even getting better? The better we can get their ambulation, the better we're going to fix a lot of other things. We have still a lot of patients that we're admitting needing supervision at all times to ambulate. And when we discharge them, we're discharging them needing supervision at all times to ambulate. So we really have to think about right up front when we're admitting them, what can we do to get them to the next level up? And that's, are they able to ambulate on a flat surface? Can they get across the room? Can they get down the hallway? You know, you might be there so that when the patient does get to an uneven surface or they might need help on and off with their ambulating, you're there. But is the patient at least able to get safely on that flat surface? So that's kind of where we at least need to start. So that's the difference between continuous and is it intermittent, moving them from a 3 to a 2. So we really want to look at that, right when we're admitting them, because you can see it in the documentation, you can see it in the charts, you can see it in, all the therapist notes. They work wonderfully with everybody, and they're stronger, they can go further, they can do more. We just have to make sure that we're letting everybody else know that, yes, we did improve this patient, and they are able to do more than they were when they first came on.
But it's paramount that when we do the Oasis, the admission, correctly
Yes.
grade them, because what happens is a lot of times they place them at a higher level, at least when I see them, quite frequently. And it's not going to demonstrate the improvements that we need to make, or in fact, even just telling someone you need to do it this way, that's assistance. They're not able to do it independently. So if they start
Correct.
off,
Yes. So like anything that you correct, even at the very first visit, you take credit for that at discharge, because when you came to the patient's house at that visit in the previous 24 hours, which is the time frame you're looking at, they weren't able to do that. You went into that home, you put in that intervention, you gave them that assistance, that advice. Now they're able to do that. We're going to take credit for that at discharge. And yeah, getting them up and moving, I mean, that's really going to be the best way to really see what it is they're able to do. So that's one of the things we're really going to focus on. So everybody needs to be aware of, what they're assessing and how they're assessing it, so that we're accurate. And then just one quick reminder, it's flu season. So at transfer and discharge, when we answer the flu question, you have to say yes now, because October 1st to March 31st. So I just wanted to remind everybody. And also this is publicly reported. So we want to really find out if our patients are getting their flu shots and recommend it. So, because that's going to be up there for everybody to see also. And the pneumonia question is gone. So,
Okay.
yeah, well, it will be in January. It will be. So, all right.
Question.
Okay. Yes.
Question for everyone is, I'm wondering about anybody's opinion on this. I've been thinking about it quite a bit. With the current that's coming up in January, even with what we do now and their assessments, and they check off anything that they ask and they check anything. I find, in my opinion, many people rehash the thing in a narrative note of what they checked off. Do you have an opinion
Okay.
on that?
You know what? So when you answer the Oasis, you're actually supposed to support your answer in your documentation. So they do want to see why you, and then also, it also helps on discharge, because when I'm looking at a chart and I see something marked and they didn't improve, I'm like, oh crap, why did they put that? And I can't find any documentation that's giving me any like reasoning behind what the answer was. And it's just like at Start of Care, like Dennis was saying, if you're answering the Oasis, their functional status a certain way, why are you answering it that way? What, you know, what's your, it doesn't have to be a book, you know, just, but some supporting documentation that someone's going to be able to say, oh, okay, that makes sense. You know, that's really what the patient status is. And that helps Julianne and Jill too, because when they're looking at it, they say, oh my gosh, look at all this about the patient. And then they can, you know, go back and help people to kind of say, oh, gee, maybe it's this, you know, versus this kind of thing. So yeah, it should be supported. Doesn't have to be a book.
Thank you.
All right.